Well, thank you for joining this Woo You webinar. This is the updated prevalence of pediatric keratoconus, much greater than you thought, with Dr. Jennifer Harthan. Thank you so much for being here. Next slide. And I'm your host, Elise Kramer. So I will introduce our moderators tonight, Dr. Barry Iden, CEO and co-founder of IKA, North Suburban Vision Consultants in Deerfield, Illinois, and Dr. Andrew Morgenstern, president and co-founder of IKA, Walter Reed National Military Medical Center in Bethesda, Maryland. Thank you so much for moderating tonight. We're so excited to be partnering with IKA and to have this event. And thanks again. I'll be back on later for Q&A.
So now I would like to introduce our speaker tonight, and all of you can read her amazing accolades here on this slide, but I'd like to share something more personal and from the heart. I've known Jen for a long period of time. She is one of the most amazing, not only ODs, eye care professionals, but such a dear friend and such a good person. She has led us towards the publication of one of the most impactful papers in keratoconus that we'll be talking about this evening. And I want to introduce my dear friend and just an amazing individual, Dr. Jennifer Harthan.
Thank you, Barry. That was one of probably the nicest introductions I've had. I am really excited to be here with all of you. Here's our disclosure slide. Have to go over this, but really just delighted to be with all of you tonight to talk about the updated prevalence of keratoconus, specifically pediatric keratoconus. And I think what's really interesting, and I hope what you take home with you tonight, is that it's really much greater than we've previously thought. And perhaps this will change the way that you practice as you move forward, as you're seeing your adult patients, but also your pediatric patients. I do want to just acknowledge several groups and several individuals. This was not just an individual project. This has been a team effort. We've been working on this for several years, and I would be remiss if I didn't thank the IKA for their help with all of this, and ICO, the institution where I work, but also Oculus for their support in this project. And just as Barry had mentioned, the individuals I worked with on this project, they have been mentors, they have been instrumental in getting this paper published, but also they are lifelong friends, and we have shared a lot with each other, and the value that they brought to this project, there are no words to express my gratitude. So as we move forward this evening, I'd like to start by discussing a few cases that many of us have seen in clinic. We're going to review some highlights regarding the clinical guidelines for keratoconus, and then we will get into what we're here for, the prevalence of keratoconus, what we've looked at in the past, where we are presently, and where we are moving in the future. So to start our discussion, let's look at this case. You may have seen a patient like this recently, you might have seen one in the past, or you might see one in the next several weeks, but this was a 12-year-old who presented to clinic complaining of blurry vision, more so on the right compared to the left, and was told at last year's school screening to present for a vision exam. And the patient had only ever had a school screening, never worn glasses, has always felt that he hasn't been able to see very well out of that right eye. Patients in 6th grade, B's and C's, and said, yeah, when I cover up each eye, I don't see very well. And sometimes we see those patients in 6th and 7th grade, and that's sort of the attitude and sometimes the response that we receive is that, yeah, maybe I don't see as well. Well, this patient, when you take a look at uncorrected vision, the patient really doesn't see very well. Entering uncorrected vision is hand motion in the right eye and 2100 in the left. Just taking, further questions and looking at ocular health, the patient does have a family history of keratoconus. But looking at the cornea, I think this is what kind of makes us pause a little bit, is that this patient, 12 years old, first eye exam, and has significant corneal scarring. And this patient isn't just mild keratoconus. If you take a look at these scans, this patient has more mild to severe keratoconus. And due to the scarring and the corneal thickness, this patient may not be a candidate for corneal cross-linking, particularly in that right eye. And if we're only seeing this patient at 12 years of age, what happened previously? Could we have done something sooner if we would have caught this at an earlier age? But let's talk about another 12-year-old. So this is a 12-year-old who presented for an updated eye exam. Had an eye exam previously, but needed another one because was going to a new school. Complaints with vision, no complaints with vision at distance or near, but did say it had slight pressure sensation in the right eye and notices it more when weather changes. And that makes sense because the patient has a history of asthma and eczema, seasonal allergies, so it tends to notice those things more when season changes. And again, no complaints with vision other than this patient's a soccer player. So when playing under the lights at night, noticing more glare. Family medical history, family ocular history is unremarkable. And if we look at this patient's exam information, uncorrected acuities, 20/25 minus in the right eye, 20/20, all entrance testing, IOPs, dilated fundus exam, essentially unremarkable, refraction, a little bit of astigmatism in that right eye, essentially plano in the left eye, and a little bit of papillae. So if this was your patient, what do? Is there anything in this particular exam that makes you pause and think, should I do any additional testing? Probably not. But what if taking a look at that dilated fundus exam, maybe you wouldn't even dilate this patient, maybe you just did photos. But what if you're looking and maybe you see something strange, maybe a little bit different on that scissor reflex when you're doing your dilated fundus exam, you were seeing a little bit of oil drop reflex. What if we didn't do additional testing? Then maybe we'd miss this. Because corneal tomography is currently not considered the standard of care in pediatric comprehensive eye care. So cases of keratoconus, specifically early keratoconus and keratoconus suspects, might be missed, particularly if clinical signs aren't present. So why is this important? This is important because we know that the younger the onset of keratoconus, these patients tend to have poorer prognosis. Their disease tends to progress much faster. And when they're diagnosed younger, they have a much higher likelihood of needing a corneal transplant. And when they have a corneal transplant, they have a much higher risk of that transplant rejecting. So what is our goal when we see these patients? Our goal is that we want to diagnose keratoconus as early as possible. But we have some challenges. Our challenge is we want to be able to get this technology to those who need it. The key is to really intervene before these patients have vision loss, like we saw with our first patient. Our goal is to identify the disease earlier. We want to implement effective corneal stabilized treatment methods. So there's a corneal cross-linking when it's appropriate, because ideally we want to prevent decline in visual outcomes and prevent decline in long-term quality of life for these pediatric patients. So if we look at reviewing keratoconus, right? We're used to looking at contributing factors, clinical signs, and we know that keratoconus is a progressive corneal ectasia. It's characterized by focal thinning, steepening, loss of that biomechanical strength. So these patients often present with increased irregular corneal astigmatism and decreased vision. We know that the condition is bilateral, it's often asymmetric, and it's progressive. And progression and worsening of the disease are more likely if the disease manifests at a younger age. There are many contributing factors that we have known and are published in the literature: genetic conditions, atopic disease such as allergy, asthma, eczema, environmental factors, and other systemic conditions are also known to contribute to the disease. Clinical signs. There are different classification systems used to look at the severity of the disease. But we also, as clinicians, often look at clinical signs. We use our judgment based on what we're finding to diagnose keratoconus. Patient might present with blurry vision, with increasing astigmatism, with changing myopia. We might see signs of apical thinning with Vogt striae on the cornea, Fleischer ring. We might see Munson sign. We might see changes to corneal staining. But these patients also might have complications, superficial apical scarring and corneal hydrops. And ideally, we don't want that to happen. There was a paper that was published in 2015. It was called the Global Consensus on Keratoconus and Ectatic Disease. This was published in Cornea, a very well-respected journal. And this paper, what came out from a large group of corneal experts. And we all know that the more research we do, the more we learn. It's great to get this information out, but there also might be more changes that come from this. That's what makes us all better. We learn from each other. But this paper was published not only to define keratoconus, but also to look at how progressive keratoconus was and to also look at the management. So but basically, the outcomes of this paper said that in order to make a diagnosis of keratoconus, we need to have documented progression in at least 2 of these 3 characteristics. So we have to meet 2 out of the 3 of these. So we have to have abnormal posterior ectasia, again, underline posterior. Okay, and there's a reason why that's important. I'll get to that in just a minute. Have to see clinically non-inflammatory corneal thinning. And what's important also is that central pachymetry is one of the least reliable indicators of keratoconus. So why is this important looking at posterior ectasia and central pachymetry? The reason why I bring this up is because of placidotopography, okay? So a lot of the instrumentation that we use in clinic is based on placidotopography. And placidotopography, when we use that, we might be missing the early diagnosis of keratoconus because it measures the front curvature of the cornea. It provides us with no analysis of the posterior cornea, and it doesn't provide any representation of corneal thickness. So if we're just measuring the front curvature of the cornea, we're going to be missing information, particularly for those subclinical cases. So that's why when we talk about corneal tomography, that is so important. Another finding that they talked about diagnosing keratoconus is corneal thickness distribution. So we're not just looking at the thinnest part of the cornea, but also how does corneal thickness change from the center of the cornea to the periphery. And why is this important? It's because this is much more abnormal in patients with keratoconus compared to patients who don't have that. So as mentioned, there are changes to the posterior cornea and corneal thickness that often occur prior to changes that impact vision. And that's what we saw in our second case that we had discussed. So these are example images from corneal tomography. So if we take a look at our images on our top left here. So this image right here shows us normal anterior corneal curvature and normal anterior elevation. But if we take a look here, this is an elevation map of the posterior cornea. Okay, so it's picking up changes to the posterior cornea before we see any changes to the anterior cornea. So this tells us this patient does in fact have keratoconus. So if we were just measuring this patient with placidotopography, we might be missing this. This would give us false negative on placidotopography. If we take a look at these images on the right here, we have an image on the front right here, and it looks maybe suspicious that maybe this patient might have keratoconus. But if we take a look at corneal thickness, we look at the anterior elevation, we look at posterior elevation, we can see that those are normal. So this is what we call false positive on placidotopography. So why might we see this on placidotopography versus tomography? Well, this might be for patients who maybe have surface disease, or maybe they are overwearing their contact lenses and have corneal warpage because of that, or maybe they've had trauma. Really what this is telling us is we see a discrepancy between tomography and topography. And corneal tomography, where we get posterior corneal changes and corneal thickness, is much more sensitive in picking up keratoconus, particularly those cases with subclinical disease, okay? The other thing that we can see here is we can see corneal thickness changes. And we'll get to that again in a little bit. We have an abnormal, we can get abnormal changes to the thickness. So if we take a look at the normal absolute thickness, I'm sorry, my mouse here. Let me get this. It's frozen 1 second, my apologies. It didn't want to work here. I apologize. We'll get to the abnormal thickness again in just a second. But really, what I want to highlight is that there are people with keratoconus, they're not alone. So this is important when we talk about prevalence, when we're talking to our patients and educating them. That I had a patient like this today, where a patient thought that this was a very rare condition. They wanted to get a second opinion on what they should do. And we used to think that keratoconus was relatively uncommon, but we now know that based on the evidence that we see in the literature, but as well as in clinical practice, that this isn't true. And this is going to be really important about how we educate patients and how we diagnose and screen and manage our patients. But what's really going to be impactful for us and really important for us is to make sure that we have the right instrumentation and the right methodology to manage our patients. So as we move into the prevalence, what we're here for, right? It's important to understand the difference between prevalence versus incidence, okay? And when we talk about prevalence and incidence, it's important to talk about this when we talk not only about keratoconus, but other diseases. And we use this for different purposes when we're answering different research questions. But prevalence, what it is, it reflects the number of existing cases of the disease, whereas incidence reflects the number of new cases of disease, and it can be reported as risk. So you often hear this reported as the incidence rate. So for the purpose of this rest of this discussion, we're going to be focusing on the prevalence of keratoconus, or the number of existing cases of keratoconus for a certain population. And we're going to end up with talking about the prevalence of pediatric population. So as we continue our discussion with prevalence, let's talk about what we already know regarding the prevalence of keratoconus, or another way to think about it is how common is keratoconus in specifically the adult population. So many of you have heard this classic reference. This is what we have traditionally used, that the prevalence of keratoconus is 1 case in 2,000 individuals. And some of you might say, I've heard this reference before, but where did this actually come from? So this statistic comes from a study that was published in 1986. And this was based on a registration study out of Olmsted County, Minnesota. And this study was conducted between the years of 1935 to 1982. What's interesting is that keratoconus wasn't detected on methodology of using instrumentation. It was detected based on older technology. It was detected on the diagnosis of scissor reflex with retinoscopy and keratometry outcomes. So when we think about that, if we're not using updated methods to detect the disease, we're probably missing the disease. So there have been many more variable reports on the prevalence of keratoconus. And as we really look into those reports, there is a large discrepancy in the prevalence of keratoconus in the adult population. And this is in part due to several factors. It's due to the age group studied, the ethnic variation within that particular population that was studied, and also the geographic and environmental differences in those populations that have been studied. The other thing that we're noticing as we're looking into these reports is that each study on the prevalence of keratoconus has used slightly different criteria to diagnose keratoconus. When we look at the literature reporting on the prevalence, the more updated literature says that it's actually 1 in 50 to 1 in 750 compared to the more classic reference of 1 in 2,000. And some of this has been due to what our understanding of the disease has been. Our understanding has changed. There was a study, it was really sort of an eye-opening study, and this was published in 2017. And this study is also referenced as the Netherlands study. This was an age-specific incidence and prevalence of keratoconus, and this was actually quite a remarkable study in that they had so many individuals that they looked at. And the reason why is because this was a nationwide health insurance registration study. So they had 4.4 million patients from a mandatory health and database, and they utilized topography. So they did use updated technology, updated methodology. So it was more sensitive diagnostic technology to detect keratoconus, maybe not as sensitive as some of our current methodologies. But what they found is that this study was much higher in the general population. They found the prevalence to be 1 in 375 individuals. So what was the ultimate conclusion of this particular study? It was that the prevalence of keratoconus was 5-fold to 10-fold higher than previously reported. And again, this is due to that updated methodology using more sensitive diagnostic technology. So even more recently, there have been more publications, more data looked at, and in 2020, in cornea, there was a large meta-analysis done, a large systematic review of 29 different articles in which many participants from 15 countries gathered. And what they found is that the prevalence of keratoconus in the whole population was 1 in 725. So what does this mean? Compared to the classic reference of 1 in 2,000, our take home is that keratoconus is really much more common than we think. And again, this is so important for how we're talking to our patients, how we're educating patients, not just on the diagnosis and looking at the progression, but also in how we manage. Again, all these studies that we've mentioned have been predominantly on the adult population. So this is great for diagnosing. And many of us, we do a lot of co-management with ophthalmology. We also do specialty lens fits. But where else is this really important for? Well, this also is important in looking at patients who are scheduled for different surgical procedures, not just corneal surgery, but other ocular surgeries. So there was a poster that was published, and they did a single center retrospective topographic review of 400 eyes, and they had 200 consecutive patients who were scheduled for cataract surgery. And when they were evaluating these patients, they found that 3% of those eyes had mild to moderate keratoconus based on topographic review. And 1.4 of those eyes had demonstrated a pellucid pattern on topographic review. And we think back to that classic reference of 1 in 2,000. If we had just used scissor reflex or maybe K ratings, could potentially some of these patients been missed? And what would those outcomes, visual outcomes, those surgical outcomes been for these particular patients? Again, looking at prevalence for other types of patients, why is this impactful for us as clinicians? Well, it's important for those patients who are undergoing potential refractive surgery. Corneal tomography is done before these patients have refractive surgery because we want to make sure that we identify any potential risk. We want to avoid any complications. And this was a publication that looked at the prevalence of keratoconus in patients who were interested in undergoing refractive surgery. And they utilized corneal tomography measurements to help detect keratoconus. And what they found is that the overall prevalence of keratoconus was 18.7% in all patients and 24% in patients who did not undergo refractive surgery. So if we break that down into sort of more simple terms on how I like to sort of phrase things to patients, that tells us that almost 1 in 5 LASIK candidates potentially have keratoconus. That's kind of like mind-blowing if you think about it that way. Well, what about our pediatric patients, right? What does that mean for us? Well, we're going to get there in just a second. So looking at the prevalence of pediatric keratoconus, this isn't necessarily something that's new, but the methodologies and how things have been looked at, maybe we needed to be a little bit more specific on how we diagnose keratoconus and that there were discrepancies in the diagnosis. So this publication came out in 2018, and it looked at the prevalence of keratoconus in pediatric patients in Saudi Arabia. And they looked at final D values, and we're going to go over how to interpret that in just a second. But what I think there's 2 important things here. They use mask examiners along with corneal tomography. So looking at that posterior thickness, looking posterior elevation looking at corneal thickness, but they also use mass examiners in combination with that objective data. So with that, there were some discrepancies in the diagnosis, okay? So that being said, they were using updated methodology, but there were some discrepancies. The average age of this population was 16.8, and the final prevalence for these patients was 1 in 21. So much higher than previously reported. So it's much higher, and the increase again could be the population varied, the geographic location, but also what's key is looking at the screening technology to detect undiagnosed keratoconus with greater accuracy. So the more detailed that we can be in analyzing the cornea, looking at other factors, if we're more accurate in diagnosing, these patients are going to have better outcomes. Many of you have seen this publication as well. This is the RAIN study. This was out of Australia. This was a cross-sectional study, and they looked at over 1,200 patients. And these was a longitudinal cohort study. These patients had Scheimpflug imaging, so corneal tomography. So in addition to their comprehensive exam and visual acuity assessment, they also had corneal tomography. And what they define keratoconus to be as a Balin-Ambrosia enhanced ectasia display score of 2.6 or more in either eye. And again, we're going to get over how to interpret that in just a little bit. But what they found is that 15 participants had keratoconus in at least one eye, giving a prevalence of 1 in 84. So again, much higher than previously reported. So what does this mean again for us? It's really important to screen young individuals so treatment can be initiated before disease progression. But what is one of the issues with this methodology, right? We talk about corneal tomography compared to topography, placebo topography, being more sensitive, more specific, because it gives us posterior elevation. It gives us corneal thickness distribution. We're not just looking at the central thickness, we're looking at the distribution thickness of the central cornea to the peripheral cornea. But the final D, the Balin-Ambrosia, that is not necessarily designed as a software, not designed to diagnose keratoconus. What it identifies is abnormal corneas from normal corneas, okay? So it's a great reference to use, but it may not be a true representation of actual keratoconus. So we've talked a little bit about some of these other studies, and there is a reason for this, okay? Yes, they are on the adult population, but it's important to talk about where we've been in the past because that brought us to where we are presently, okay? There are challenges with some of those previous studies. Yes, we use them, we reference those, we use those to educate our patients about the importance of monitoring keratoconus, to monitor their progression. We use them to treat them. But the challenges with the previous studies is the population studied, right? How keratoconus was defined, the geographic and environmental differences among those populations. But one of the key limitations with some of those studies, specifically the studies that use current tomography indices that we use to diagnose keratoconus early, we monitor keratoconus closely, is that normative data with corneal tomography hasn't really been well established for the pediatric population. So as such, there's limited evidence for the pediatric population. And that brought us to where we are right now, what we're going to be talking about as far as the paper that we worked so passionately on. So if we look at, again, more of that evidence-based research, prior to the advancement of corneal diagnostic technology, the literature has reported keratoconus to manifest clinical signs and symptoms during the 2nd to 3rd decade of life. Are we even looking for this in patients who are younger than that? The prevalence of keratoconus in the pediatric population is not well established. But it's interesting. I recently did a PubMed search, and just this past year, there have been more and more publications looking at not only the prevalence and associations of keratoconus in children, but looking at more of the associations of keratoconus and allergy, looking at using those advanced diagnostics in pediatric patients so that we can not only diagnose keratoconus, but we can really look at that subclinical disease. So what we're going to do for our remaining time here is I really want to highlight the work that we've done on looking at the prevalence of keratoconus in pediatric populations, specifically pediatric population in Chicago. Again, this was work that was done. A group put a lot of sweat and tears in this and generously sponsored by IKA. Thanks to Oculus again for allowing the use of corneal tomography. But basically what this was, it's a prospective observational single center study. So what that means is that subjects between the ages of 3 to 18, so any subject who presented for a comprehensive eye exam between the years of 2017, 2019 at the Princeton Vision Clinic. It's a community-based program run by the Illinois College of Optometry, and this clinic primarily served the pediatric population within the Chicago public school system. So any subject that presented had a comprehensive eye exam. And in addition to assessment of visual acuity, dry and wet refraction, binocular vision testing, health examination, every eye on every single subject had image capture from the pentacam. So we had mentioned before a little bit about looking at corneal tomography and looking at what we had called the Balin-Ambrosia enhanced ectasia display. And we mentioned that previous literature has reported the prevalence of keratoconus in several populations, only using the BAD3 final D. Well, what is this? Okay, so again, this was not designed to diagnose keratoconus. What the final D was designed, and what this whole Balin-Ambrosia BAD3 final D enhanced ectasia display was designed to flag abnormal cornea from a normal cornea. So let's talk more about this final D, because some people are like, I don't even know what that is. Okay, so it's sort of complicated, but not really. Okay, so basically what it does is it uses different variables. Okay, and it gives us 5 different variables that are listed below. So you see those codes on the color codes on the bottom. You see 4, 1, 2, 3, 5 on the 5 red and 1 yellow. Okay. So what it gives us is it gives us 5 variables. They're as sub D values. Okay. And what they denote is they denote the standard deviation from the mean of the normative adult database. Okay. So what does it all include? It includes anterior elevation, posterior elevation, corneal thickness at thinnest point displacement, and pachymetric progression. Okay. So the results of the scan, okay, they're going to show the 5 visible sub-D values. They're color-coded, okay, and how they're color-coded is based on their standard deviation from the mean. So white basically means normal, okay, so that's when the values are less than 1.66. Yellow is when they're greater than or equal to 1.6, and that means that this is when, okay, we should be cautious and monitor. And red is when it's really flagged and when it's greater than or equal to 2.6, okay? And then final D is calculated when considering all 9 of those variables, the 5 shown and the 4 not shown, okay? And it performs basically a regression analysis against the standard database of a normative adult population. So again, this is more specific, okay, sensitive, but to improve the specificity of keratoconus, what we did is we added the back elevation at the thinnest point to diagnose keratoconus for this particular study. Okay, so that's how we designed the study, the methodology, to make it a little bit more specific versus just highlighting, is it a normal cornea versus an abnormal cornea? Okay, so I know that was complicated, but it's important to highlight, and that's how this printout is interpreted and how we used it to diagnose keratoconus. So again, this is the tomographic criteria to diagnose keratoconus. We have normal, keratoconus suspect, and keratoconus. So we combine that final D plus the back elevation at thinnest point, both for our myopes and hyperopes with astigmatism. We all want to know what the results were. So some people think, why bother doing tomography on children because they can't sit still? Well, tomography data from over 2,000 subjects were recorded. And once we eliminated duplicate scans or poor quality scans, we had data from still 2,007 subjects, almost 4,000 eyes. Okay. So what does that tell us? That tells us that kids can sit for this technology. Kids can sit for corneal tomography. Over half of the subjects were female. The average age was 11.4 years. And ethnicity for this particular population, 60.7% were Black and 34.5% were Hispanic. Okay, so again, this was a specific population. Taking a look at the results of prevalence, again, if we look at keratoconus, the results, prevalence 1 in 334. And that's significant, right? That's, again, higher than what was classically referenced. But for me, and I think for all of us who have worked on this, is not just those patients with keratoconus, right? When we see keratoconus, we know it. But those children, these pediatric patients that we really have to watch are those suspects. And when we combine total keratoconus and keratoconus suspect, that prevalence goes up to 1 in 223. That's much higher than I know I thought the prevalence was. Perhaps it's much higher than you thought. So what is the significance of all of this? We've talked about a couple of patients. We've looked at the diagnosis of keratoconus. We've talked about past prevalence data. And now we're talking about what we're seeing now in this particular population in Chicago. What does this mean? Well, what it means is that the prevalence found in this study is higher than previously reported. And it's one of the studies done on pediatric patients. And why is this important? It's because early diagnosis of keratoconus is so important. Utilization of using corneal tomography, not placido topography, but tomography is critical. We want to recognize progression, and we want to intervene timely with corneal collagen crossing, because we know, as we've seen in our adult patients, this has been so successful and so imperative to prevent progression of disease, avoid vision loss, and to impact a patient's quality of life. And this can be even much more impactful when we're talking about children. We have the opportunity, when we're diagnosing these patients earlier, to really affect quality of life, their social development, and their educational development. So diagnosing earlier is so critical. The other thing, we had talked about, corneal tomography is not considered standard of care in the pediatric population. So looking at the frequency of abnormal corneal findings in this population, yes, this is a population in Chicago, but because the frequency of the abnormal corneal findings in this particular patient population is so high, it warrants, we need to consider changing how we're doing things. We need to implement more universal screenings for keratoconus in our pediatric populations. We don't want to be the reason for our patients having vision loss when we had the opportunity to diagnose them. We can change things. So again, it's not just for those patients who we can diagnose with keratoconus, but we really want to watch those patients with subclinical keratoconus. So that's the present, that's the significance. And I hope that you sort of feel the passion that I do. And you've heard from Dr. Iden and Dr. Morgenstern, and you hear from others. So where does that take us to the future? There's more steps, right? So this was one study. There's more work to be done. There need to be further large-scale, multi-center studies are needed to understand the prevalence in more of the general population. More work needs to be done. I had mentioned that screening for keratoconus and keratoconus suspects should be part of routine pediatric eye exam. And for those who also show high risk factors, those who have high astigmatism, they have reduced best corrected visual acuity, those who have a family history of keratoconus, those who have abnormal corneal findings, right? Those we should be more aggressive with in terms of doing more screening, looking and monitoring them closely and intervening earlier. We also should be looking at more of the biomechanics of the cornea as well. So I think you're going to start to see more and more work done looking at specifically the pediatric population. But I hope that you take with you from tonight that the prevalence of keratoconus in the pediatric population is higher. I hope that you start looking for this in your pediatric population. And if you don't have the tools to do so, refer to your colleagues. They're going to refer them right back to you. But I think that we have such a great opportunity as an eye care community to do really great things for our patients. And I thank you for your time.